Today I was going to talk a little bit about sleep apnea, and feel free to ask any specific questions you have as we go. The sleep apnea, by definition, is an apnea-hypopnea more than 8 events per hour on a sleep study. What's an apnea? An apnea is a period on a sleep study lasting 10 seconds where there's no airflow. And what's a hypopnea? It's a less severe apnea. A 50% reduction in airflow for at least 10 seconds with a physiological consequence, a cortical arousal or a drop in oxygen level. There's a lot of, the prevalence varies according to the various definitions used, but it's pretty common, and men are affected more than females. About 15% of men, 5% of females. We see men in their 40s and 50s and women in their 50s and 60s. There's certainly a hormonal impact on the presentation of sleep apnea. In terms of those patients that are overtly symptomatic, it's probably around 4% of men and 2% of women, and snoring is more prevalent. In terms of severity, we all get a printout of an AHI, and that's the traditional way of determining severity in sleep apnea. A normal less than 5 and severe more than 30. I think severity is a little bit more complicated than that, and certainly when I look at a sleep study, I'll look at the impact of arousal, sleep fragmentation, and quality of sleep. And I think hypoxia also is important, so I'll look at desaturation events as well. I think they're also important in severity rather than just purely a simple number, a simple AHI. The symptoms are straightforward. The most predictive symptom of sleep apnea is the witnessed apneas and nocturnal choking, and those symptoms have a sensitivity and specificity around 60 to 80%. These patients complain of an unrefreshing sleep and daytime sleepiness, particularly in passive situations. As you know, we use the Epworth sleepiness scale, which describes patients describe their symptoms of sleepiness in 8 situations, and any number more than 10 is consistent with a subjective report of sleepiness. The higher the number, the more sleepy they are. Sleep apnea is a risk factor for motor vehicle and workplace accidents as well. We see a lot of memory and concentration problems, and certainly depression as well. Certainly sleep apnea and depression tend to coexist, and certainly it's not unusual to see a sleepy patient that's referred that doesn't have sleep apnea that purely has depression and daytime sleepiness. You're aware of the cardiovascular consequences of sleep apnea as well, particularly hypertension and cardiovascular disease. The risk of stroke is highest in males. The treatments you're aware of, weight loss improves the apnea-hypopnea index in the majority of patients. About 1 in 4 patients we see, though, do have a normal BMI, and their sleep apnea is explained by craniofacial abnormalities and genetics rather than body mass index. The majority of patients have positionality to their sleep apnea, meaning they have more frequent events when they're on their back. So simple avoidance of the supine sleeps can be quite important. In those patients who have events exclusively on their back, the traditional recommendation was a tennis ball in a sock pinned to the back of their pyjamas. The feedback from patients doing that is pretty disappointing, and they certainly don't. I haven't had very many impressed patients when I've given that advice. There are some commercial devices. There's the BuzzPod, and there's a couple of other devices as well that sit sort of on their chest and gives them a little buzz when they go onto their back and gets them back onto their side. The patients that I've used that are usually quite happy with it. It gives them a printout in terms of the time they spent on their back and in all body positions overnight. It also has a decibel trace as well, so they can monitor their snoring as well. Alcohol makes sleep apnea worse, and as does smoking. Smoking causes edema in the upper airways and exacerbates sleep apnea. Treating nasal obstructions helps snoring. It can help a little bit in mild sleep apnea. It doesn't do much in severe sleep apnea other than improve nasal patency and potentially tolerate a nasal mask. So the sort of masks we prescribe, our inclination and our preference is always to prescribe a nasal mask, and that requires a patient to have nasal patency. There's two, you can see the standard sort of nasal mask there. And nasal masks are better for patients because when they roll over they don't get leaks and it's sort of a little bit less cumbersome, although most patients find everything cumbersome. So that's sort of a standard nasal mask. There's also pillows as well that go directly up into the nasal cavity, and so that's a bit less overwhelming for the patient. But in those patients that have nasal obstruction or who are determined mouth breathers, then we'd have to use a full face mask, which is certainly more cumbersome for them and certainly leads to more leaks when they roll over in bed. We might just be one-trick ponies in terms of doctors that just always prescribe CPAP, but this is mainly because it is highly effective and safe, and it is our gold standard treatment. If we can have a patient using CPAP, more or less, we can be pretty sure that their sleep apnea is going to be treated. But the big problem, as you know, is compliance, and there's many CPAP machines sitting in cupboards at home not being used. So a second line treatment are dental devices, and these are mouth guards for the top and bottom jaws that are adjustable, and they're pushing the mandible forward. As you push the mandible forward, you open up the airway. You also pull the tongue forward as well. The tongue adds to the obstruction in sleep apnea by relapsing back into the throat. We use them in patients with mild or moderate sleep apnea with a lower BMI, and they're best for patients that are worse, that have positional sleep apnea. Compliance is certainly better than CPAP, but the patient does need to be followed up by a dentist as well, because they can move the teeth over time. I think it's important when they do get their splint though to have a sleep study with the splint in, a so-called splint review study, to prove that the splint's working, particularly if you're treating sleep apnea. I've seen a number of patients who have worse sleep apnea with their splint in. Surgery, the old UPPP surgery is out now, and I wouldn't recommend it. The long-term results are poor. Nasal obstruction, I think it's worthwhile unobstructing a nasal cavity. They're more likely to tolerate nasal masks. They're probably going to snore a little bit less also. However, if someone has big tonsils, I think getting big tonsils out is probably worthwhile. Craniofacial abnormalities we see often or occasionally in sleep apnea, and you'll often see men come in and they'll have some weird hair growth sitting right on their chin, and that's usually a sign that they've got retrognathia and they're just trying to cover that up. So in patients with extreme retrognathia, a facial-maxillary surgeon can bring the jaw forward. Obviously it'll have a potentially cosmetic benefit as well. In patients with macroglossia, a tongue reduction is also an option. So treating these patients is difficult at times, and the patients that do the best are the patients with a more severe sleep apnea and have more sleepiness. Clearly, if the more sleepy you are, the perceived short-term benefit from treatment is obvious, and so patients are going to do better. It's much harder getting patients that have no symptoms of sleepiness onto sleep apnea, obviously. The evidence for sleep apnea is certainly well and truly in now. Certainly in the right patient will improve their sleepiness, both subjectively and objectively. It improves their quality of life, and and they'll certainly do better on cognitive testing as well. As I was saying, the patients that do best tend to be the more severe patients with sleepiness. So in our patients who are unhappy with CPAP and not using it, we have to consider the other possibilities. Maybe their sleepiness was unrelated to sleep apnea and they actually have narcolepsy or depression. Maybe they have restless legs. And again, maybe their sleep apnea is not particularly symptomatic, and and their sleep quality, despite their sleep apnea, was good prior to treatment. Clearly, wearing a mask is going to disrupt the quality of your sleep in the short term. Sleep apnea and heart problems. So the association between sleep apnea and hypertension is well and truly proven now. And that association is clearly independent and was well demonstrated in the Sleep Heart Health study. There was a famous prospective cohort study of hypertension and sleep apnea, and this is quite old now, and they monitored patients with a diagnosis of sleep apnea and watched them for the subsequent diagnosis of hypertension. Those patients with more sleep apnea developed more hypertension, and there was a clear dose-response relationship. We get quite a few referrals from cardiologists now in difficult to treat hypertension patients as well. Certainly in difficult to treat hypertension, sleep apnea is well and truly overrepresented. This is the Wisconsin hypertension study. This was looking at patients with sleep apnea and the likelihood of being diagnosed with hypertension over 4 years. And all the other modifiable risk factors were controlled for. And as you can see there, if you had an AHI over 15, over 4 years, your odds ratio for developing hypertension was 2.89. So we always think about sleep apnea in patients with hypertension, particularly when we're seeing young patients on a number of agents. Other things to think about: nocturnal ischemia, again associated with sleep apnea, and CPAP tends to control angina in these patients. Indeed, the apnea index is an independent predictor of myocardial infarct. So sleep apnea is associated with increased cardiovascular mortality. There was the GAMI study in the New England Journal, which showed an increased risk of sudden death in sleep apnea patients between midnight and 6 a.m. I'll have a look at that. As you can see in those first 3 bars on the left, that's between midnight and 6 a.m. The white bars, the sleep apnea patients, and as you can see there, they're much more likely to suffer from sudden cardiac death compared to the general population of patients without sleep apnea. It's another really nice study, the Marin study, that gets quoted a lot. It was published in The Lancet. This patient looked at patients that went through a single sleep lab and followed them up for over 10 years. They looked at fatal and non-fatal cardiovascular events in patients, in controls, in snorers, in mild sleep apnea, severe sleep apnea untreated, and sleep apnea treated. This is probably one of the most powerful studies we have. And as you can see there, over that 10-year period, if you have severe untreated sleep apnea, your risk of a fatal cardiovascular event is around about 1% per year, compared to about 0.3 to 0.5% per year in the other groups. The risk of a non-fatal event is around about 2% per year and about 0.5% in the other groups. So when I'm dealing with my uncompliant patients with severe sleep apnea, I think that's a reasonable graph to show them in terms of what potential pathway they want to take. Scare tactics. Arrhythmias are overrepresented also in sleep apnea, particularly in patients with more severe disease. Certainly, we certainly see more atrial fibrillation, particularly if it occurs overnight, non-sustained VT, and frequent ectopics. So this summarises the cardiovascular issues. Sleep apnea of any severity is a risk factor for hypertension. Severe sleep apnea is a risk factor for a substantial number of adverse cardiovascular outcomes. But I'd finish off with sleep apnea and driving. Sleepiness and sleep apnea are separately associated with an increased risk of motor vehicle accident. Sleep apnea increases the risk by 2 to 7 times and is certainly associated with impaired performance on driving simulators. Treatment with CPAP, as we said earlier, will reduce symptoms of sleepiness. It does reduce the risk of motor vehicle accidents back to control levels. And it has been shown to improve driving simulator performance as well. It's always hard to predict risk in an individual who you see with sleep apnea. There is marked variability to cope with sleep deprivation, and obviously there's good drivers and bad drivers. But most patients with sleep apnea have never had an accident despite their sleepiness. The risk factors that we talk to patients about, sleep restriction is a risk factor, circadian factors, particularly nighttime drivers and commercial drivers, young men, and of course drugs and alcohol. So the patients that I look out for in a sleep clinic are patients that have had prior road accidents or near misses. They report sleepiness when driving, obviously, and if their Epworth score is more than 16, then that's pretty, puts them in a fairly high risk category. In a sleep lab, we do tests to sometimes to reassure ourselves and Vic Roads. And the objective test of sleepiness we do is either a mean sleep latency test or more likely a mean wakefulness tests. What to tell patients: increased risk of accident from any cause. Most fall asleeps do have some prior warning. Patients need to be careful. Avoid driving if they're sleepy. Don't drive if you don't have to drive. Adequate sleep hygiene. Again, we're trying to tell them to not be sleep restricted as well. And again, if they're high risk with those high risk factors, I tell them not to drive, which obviously has some pretty can have some pretty substantial impact on their lives. At the end of the day, the onus of reporting is on the patient to Vic Roads. So I guess to summarise, severe sleep apnea is a significant disease burden. It's associated with symptoms, cardiovascular disease and car accidents. Treatment improves symptoms, quality of life, some of the cardiovascular parameters and certainly the crash risk.